Okay, so we're going to be starting with Module 8's recording, and we're going to go through some certain musculoskeletal conditions that are a little more commonly seen with our pediatric population. Fractures obviously are very commonly seen in your pediatric population. Basically, the bone, there is more stress applied than the bone can absorb. The most common cause are falls, car or bicycle crashes. Those are the most common causes of fractures. Characterized as either open or closed. They do have different surgical procedures that they perform. So for a closed reduction, they don't open the skin at all. The bone is aligned and then they put the cast on. For an open reduction, that is an actual surgical procedure where they actually go in and they align the bones, or they insert different instruments, nails, rods, things like that. Some complications that may occur because of fractures. Compartment syndrome is probably the one that you may have heard about most frequently. Basically, that is where you have swelling occurring. If they have a cast applied, say, I'm going to use that as an example, it causes pressure on the extremity, and it can lead to nerve damage or to ischemia because the blood supply can actually be cut off. Shock, fat embolize, that's a very common complication, and it's actually a very serious complication with a fracture. So actual globules of fat get into the circulation. Remember, there's a conduit to your circulation within the bones. And then, of course, DVTs, because they're not ambulating like they normally would, and the immobility causes an increased risk for DVTs. If they do end up with DVTs, that's an increased risk of your pulmonary embolism or infections. If they have a compound fracture where the bone actually protrudes through the skin, they will have an increased risk of infection. Or again, if they have to have surgical procedures done, that also increases their risk of infection. Or they can get an actual infection in the bone, which we are going to be discussing in a little bit. Okay, so the different types of bone fractures. The transverse is where the fracture goes right across the bone, as you can see. The linear, which is more of a vertical type of fracture. There are two different kinds of oblique fracture, the non-displaced and the displaced. So the non-displaced kind of has an angular appearance to it on the bone, but the bone is not separated. But with the displaced, as you can see, the bone is actually separated. This is where you may see your compound fractures, where the bone actually protrudes through the skin. Your spiral fractures, which is an indication of abuse because the bone is actually twisted, which causes the fracture. Your green stick fracture, which is not a complete fracture, it's only a part of the bone that is fractured. And then the comminuted fracture, where they actually have fragments of bone inside the fracture. As you can see in the picture there, that is a very good representation of a comminuted fracture. These kinds of fractures may occur because of impact injuries. So if a pediatric patient had a fall and they landed on their feet, the impact that would go through the body from that fall is what would cause a comminuted type of fracture. This slide here shows you some x-rays of different fractures. If you look to the top left, that's a very good example of a displaced fracture where the bones are actually separated. The two in the, the one in the middle and the one off to the right shows some of the applications that they can do if they had to do an internal fixation. So they can apply these different appliances to the bone to help the bone stay together and to heal. They can have issues when they have to have actual things placed. Obviously, it's a foreign body, so they may have an increased risk of reaction to it, but maybe it's not going to hold up very long, and at some point in time they're going to have to go back in and do another surgical procedure to either remove the appliance that they placed or to replace what they put in there. So, there are risks involved with any of these types of issues. Okay, so let's talk about nursing care for fractures. Obviously, we need to obtain the fracture history, what led to the fracture. The bones would then need to be immobilized with either splints or casts. They can apply braces to the extremity to immobilize it. If they have an external fixator, they're not going to be able to be discharged with that. They're not going to be able to walk on that. They're not going to be able to move their arm if it's on the arm. They're going to have to be inside the hospital with that. That's not something that we could send them home with. We need to be monitoring the neurovascular assessments very closely because of things like compartment syndrome that I discussed a few minutes ago. And it can cause ischemia or actual loss of blood supply to that extremity. So we need to be monitoring that very closely. So color, motion, sensitivity, we're asking them, do they feel pins and needles feeling? Are they feeling any numbness? We want to tap on the fingers or the toes to make sure that they can feel that. Make sure they can move their fingers or their toes, whichever it is that is fractured. Obviously, we want to manage pain. We want to make sure that they have some sort of medications. Either if we're sending them home, then they have prescriptions for medications. We want to make sure that we are educating the parents about pain management and how important it is. Obviously, we want to prevent infection. If we're sending them home, we want to make sure that we're educating the families about ways to prevent infection. If they've had some sort of a surgical procedure and we're discharging them from the hospital, again, we want to make sure that we're educating them about preventing infection. If they have traction, we would be providing pin site care as a way of preventing infection, because with traction, they actually do have pins that go in and attach to the bone to maintain the alignment of the bone while the bone is remodeling and while it's healing. Children do tend to heal faster than adults because they have a higher metabolic rate and their epiphyseal growth plate is still open. Damage to the growth plate can cause limb discrepancies because it actually will interrupt the growth process of that limb. So that's definitely something that we need to identify when we're doing the x-rays to decide, to see whether or not that fracture does take place at the growth plate site. Okay, so different types of casts. If it's the upper extremity, you can have a cast that kind of goes up into the anacube area. They can have a full arm cast, which goes all the way up to almost their shoulder. Down below, you can see a leg cast that kind of goes up to the knee area, but they can have a full leg cast that goes all the way up to almost their hip area. In the bottom right here, you are looking at hip spica casts. So this would be more for your toddler age kid, but I mean, an older kid could end up in a spica cast. Another way of describing it for some could be it's similar to a body cast. They actually have no mobility whatsoever when they have this type of cast on. There's two different types. There's the half spica cast where only the one leg is all the way down to the ankle. That's actually where the fracture is at. Or bilateral if both legs are involved. So obviously we need to be educating the families about keeping the cast clean, especially if it's a really young child that maybe isn't potty trained yet. We want to prevent skin breakdown when they have a cast, whether it's the hip spica cast or the arm cast or the leg cast. We do what we call pedaling the cast. That helps to prevent irritation against the skin from the cast. We want to make sure that we're educating them about bathing. They want to prevent the cast from being fully submerged. There are some casts, though, that are waterproof, and they can, take baths with those type of casts. But they have to make sure that they dry them completely, making sure that they don't let the wetness remain inside the cast. But we don't want them to be using a blow dryer to dry out the cast. That's not a good practice. Okay, so your 5 P's of a fracture. So pain. If they're having something called, if they're having symptoms of compartment syndrome, pain unrelieved is usually the #1 symptom that you're going to see first. Pallor, so the color of the extremity actually changes. Pulselessness, so if you have access to the pulses and you don't feel them any longer, that's obviously an indicator that there's a problem. Paresthesias, the pins and needly feeling, or paralysis. There's also one that's not on the slide here, but I'm going to mention it. It's called poikilothermia. So there's actually 6 P's. Poikilothermia is where it feels cool. You know, that's definitely something that we're checking when we're doing those neurovascular assessments. We obviously want to elevate the affected extremity, but you don't want them to go above the heart, because if there's an issue going on with their circulation, that can sometimes make it worse. Good hygiene, bathing, and or perineal care if they have a hip spica cast, or even if they have a full leg cast. Obviously, good peri care is going to be important. Preventing constipation because of the mobility issue, preventing infection, as we already talked about. Educate the parents about the fact that the child will experience itching because of the cast, because the skin is not getting air, because of healing process. Sometimes they have itching, but not to let the child put anything in the cast for the itching. Cast removal, when they take the cast off, one extremity obviously is going to look smaller than the other because of atrophy. It hasn't been used. That extremity muscle has not been moved. So it's going to look smaller. It's going to be weaker. So sometimes they may have to have some therapy after the cast is removed to strengthen that extremity. And making sure that we're assessing the child's emotions. It's very scary. It's very painful to have a fracture. It's very scary to have this application applied, and it limits a lot of their activity. So, we definitely need to be assessing for all of those things, and we need to be educating our families on what to expect. Again, providing that anticipatory guidance. That's very important. I did touch a little bit on compartment syndrome, but basically it's the fascia is a very tough layer that surrounds the muscle, and it's not stretchable, it's not movable. So when there is inflammation of the tissues from the fracture, or fluid accumulates under there, it's going to cause pressure because it cannot expand. And if they have a cast, not only do they have the fascia to be concerned about, but now they have the cast as well. And as I said, it can cause ischemia. It can cause necrosis because of a cutoff of the blood supply, and it can cause nerve damage. So the classic symptom is the unrelenting pain. You give them something for pain, but when you come back to check them, they now tell you that the pain is either the same or it's gotten worse, usually a 10 out of 10. The priority intervention is obviously we want to prevent the compartment syndrome, but if it does occur, we want to have fast action. We want to be able to get a hold of that provider really quickly and have them come in and investigate the problem, because nerve damage can happen very quickly. Ischemia can happen very quickly. Doing those frequent neurovascular checks, assessing for the 5 Ps that we discussed. Elevate the extremity above the heart, yes, but in some cases, no. It really depends on the circulation. We want to, reduce the swelling, but at the same time, if it's arterial, we don't want to go too far above the heart. So we do need to be careful of those types of things. And apply ice. That's another way of reducing the swelling. Traction is not as commonly seen in the pediatric population as it once was, but basically the whole principle of traction is to immobilize the fracture, to align the bones while they're going through the healing process, the remodeling process. There's 2 types. There's skin traction and there is skeletal traction. But as I said, it's not as commonly seen in the pediatric population nowadays. Here are some examples of skin traction. So you have Bryant's traction, where the legs are wrapped and they're elevated up above so that the kiddo can't move. This is more commonly seen in the younger child. And then the Russell's traction, where again, the extremity is wrapped, it's elevated, and then you have the weights on the end of the bed. I've never taken care of anybody with Russell's traction, but I have taken care of kids in Bryant's traction, and I can't say that it was all that successful, especially with the really young kids, but it is something that you may or may not see. Nursing care for traction, obviously those neurovascular assessments are going to be very important every 4 hours if the kiddo is stable, more frequently if they aren't stable, if there's some sort of circulatory issue going on. Skin care, looking at the pin sites if they have skeletal traction, checking the skin if they have skin traction, obviously because they have those wraps around them and the skin is not breathing. So actually skin care is very, very important for a kiddo that's in traction. Um, Traction weights are checked. They need to be off the floor. The extremity needs to be in proper alignment because if it isn't, then the traction's not working. If the kiddo is in traction, they're going to be in it for a while. The longest I ever had of a kiddo in traction was about 5 weeks. And that's a long time for a kid to be in the hospital. So providing them with diversional activities, keeping their brains occupied because kids get bored very easily when they aren't active. Here's some examples of skeletal traction. Crutchfield tongs, they are intimidating looking. I've never had a kiddo with the tongs, but I did have a kiddo that had halo traction. So it's quite an intimidating looking device. If they have a neck fracture, they'll have halo traction to prevent movement and to maintain alignment. The type of traction I most frequently dealt with was the 90-90 traction that you see there. That's an example of femoral traction, but they can also do that with the arm. If they have skeletal traction, the weights are not removed. They need to be adjusted. Maybe they need to add more weight or take weight off. They will take frequent x-rays when they're in skeletal traction to see the alignment of the bones and decide whether or not what they're doing is working, but they are not removed. They do have a risk of compartment syndrome with skeletal traction, so the same nursing care applies as it would apply if they had a cast, so neurovascular assessments, watching for the 5Ps, preventing skin breakdown, assessing the pin sites for infection because that's a break in the skin, so we need to be managing that, making sure that we keep them clean. Manage their pain, good nutrition and elimination because they're going to be immobilized. They're not going to be getting up and moving around. And good nutrition for the healing process. Assess for any other complications, osteomyelitis, which we're going to talk about in a little bit, pneumonia because of the immobility, circulatory compromise or ischemia if they develop compartment syndrome. Those are all things that you're going to be monitoring very closely with anybody that has skeletal traction. On page 1170 of your textbook, box 29-3, it goes into a little more depth about the neurovascular assessment, obviously pain. Is it relieved with the medications that we're giving them? Does it become worse when the fingers or toes are flexed when we ask them to move them? Sensation, do they feel touch to the affected extremity? Do they have any numbness? Do they have the pins and needles feeling, the paresthesias? And motion, can they move their fingers and toes or do they have issues with that? If they have lack of movement, it could indicate nerve damage. So obviously we want to notify the provider immediately. So definitely review that box in your textbook. That's got a lot of really good information in it. Continuing on, temperature. Remember that poikilothermia that I mentioned a little bit ago? We want to make sure that the extremity is nice and warm because if it's feeling cool, again, that could be a circulatory issue. And the cap refill time. You know, you want to definitely make sure that you're checking. So the picture in your bottom right there is an example of checking cap refill. And by now you guys should be very familiar with how you do that. But it's very important with somebody with a fracture. It is a very important part of the neurovascular assessment because we want to make sure that their circulation is intact. Perfusion to that affected extremity is very important to monitor. color to the affected limb. Remember, the pallor, that's one of the P's that we are assessing. Pink is the norm. It maybe in some cases could be a little bit paler, but it shouldn't be significant. Because if it is significantly paler than the unaffected extremity, that's an indication that circulation is poor. If they have a lot of edema to that extremity, sometimes it might look a little bit paler, but like I said, it shouldn't be significant. Pulses, checking the pulse where you can. Now, if they have a arm cast, you can actually squeeze one of your index finger kind of underneath to feel the radial pulse. You can feel the pulse in the thumb. If it's in the foot, you can hopefully get your, and again, your index finger under there enough so that you can feel the pedal pulse. But those are very important because pulselessness, again, is one of those 5 Ps. Osteomyelitis, hopefully you guys are familiar with this term, but it's an actual infection of the bone and the surrounding tissues. These patients will definitely require long-term IV antibiotics, as long as 6 weeks in some cases. So they're obviously going to have a central line placed. They're going to have antibiotics even after they go home. This can become a very significant issue to the point where they may require surgery if they can't get it to resolve with the antibiotics. So obviously this is going to require a lot of education on the part of the nurse for the patient and for the family. Signs and symptoms of osteomyelitis, they may complain of pain to the affected bone. They may have a fever because, again, it's an infection. They may have some guarding of the limb, localized tenderness, redness, warmth, pain with palpation. So obviously, nursing care, maintaining the IV site and administering the antibiotics as prescribed. Like I said, it's going to be long-term antibiotics in most cases, so they're going to have a central line, like a PICC line. Manage pain, good nutrition, promoting rest, diversional activities if they're in the hospital, and teaching the parents about the importance of antibiotic compliance in this particular case to prevent spread of the infection or to prevent ischemia to the bone. Just really briefly, clubfoot, a congenital defect, that's actual positioning when the baby is in utero. This does require, in some cases, surgery. They have cast applications that they can do where they align the foot and they apply a cast. This can happen frequently. They have cast application that happens every so often with that foot to try to get it to be in the proper alignment. Cast care, neurovascular assessments, managing pain, because in some cases that can be painful. Postural, as I said, resolves with stretching and casting. Idiopathic, where it's more congenital, depends on the severity as to what the treatment will be. Neurogenic, so kiddos with spina bifida, a lot of times are going to have clubfoot. And syndromic, which is associated with other anomalies that they may have. And in some cases, with some of these more rare types, the neurogenic and the syndromic, they may require surgery. Scoliosis, I believe they still perform scoliosis checks in the grade schools. You have the patient bend forward and then you're looking for spinal alignment. So basically, scoliosis is a curvature of the spine. There's different severities of scoliosis. The picture to the far right there is a more serious form of scoliosis, and that person may actually require either braces to be applied, or if it's significant enough, if the curvature is bad enough, it could actually affect their respiratory status. They may actually have to have surgery to resolve the problem. Obviously, this is going to cause physical abnormalities, and kids don't want to be different. They want to look like everybody else. But somebody with a scoliosis issue may look different. Their posture obviously is going to be affected. So this is going to affect their self-esteem. This is going to affect their own body image. So this is definitely something that we need to be very supportive in. I already touched on some of this in the previous slide, but nursing care, perform the screening. So if you plan to be a school nurse, this is definitely something that you are going to be doing. Discuss need for bracing or exercises depending on the severity of the scoliosis. If they do need a brace, obviously making sure that they're wearing it. Again, it could affect the body image, especially for your school age child or the adolescent. And again, surgery if the lungs are affected because of the posture. Okay, so now I'm going to get into integumentary conditions. Again, I'm going to go over the most common ones that you see with the pediatric population, not every single one that is covered in Chapter 30. It's important for you to understand them and to know them, but I'm basically just going to cover the most common. So this slide here is talking about the different types of lesions that you may see: macules, papules, patches, nodules, tumors, vesicles, pustules, bullae, and wheals. Secondary lesions are results in the change from the primary lesion, so they may develop crusts, they may develop scales or lichenifications, they may develop scars. Keloids is a type of scarring. They could have fissures, they could have erosions or actual ulcerations. Lesions, there's lots of different types of lesions. I'm not going to go through all of them because there's so many different types. But just so that you're aware that this is something that can occur with the pediatric population. Impetigo is a common problem with the pediatric population, found on or around the mouth. Some of them can be pretty significant. They begin as a vesicle or a pustule. They can have honey-colored crusts from the exudate. They can be very itchy. It's contagious. It can spread to others, so definitely need to be educating the families about that. Good hand washing to prevent the spread. Oral antibiotics are going to be necessary. Sometimes topical antibiotics as well are going to be necessary with this issue. Ringworm is another common issue with your pediatric population. Now, these pictures that you're seeing on these slides are very serious cases of ringworm. I have never seen one quite this bad, but you know, it's just important for you to know that it is out there. Signs and symptoms: round, scaly lesions. So if you look on the leg there, that's a definite classic ringworm presentation. Small black dots on the scalp or itching as in the picture up above. So obviously it's a fungal issue. So we're going to be giving oral antifungals, discuss if it's in the scalp, antifungal shampooing. Discuss that everyone in the family needs treatment. No sharing of hairbrushes or bath towels because again it is contagious. Provide emotional support, because obviously it's not a very attractive looking problem. So you're going to be needing to be very supportive to not only the patient but to the family as well. This can be kind of scary for parents if their kid presents with something like this. So we need to be providing a lot of emotional support. Lice obviously is a very common problem in your pediatric population, especially your school age population. Affects mainly the scalp, and a lot of times kids that have longer hair, the lice sometimes can be more frequently seen with kiddos with longer hair. They can't just be brushed off. They have to actually treat the lice. They do the Quell shampoo treatments. You can buy those over the counter. It's not something that they have to be hospitalized for. Most parents know what lice is. They've heard about it. You hear about it when you're a kid, or you may have experienced it as a kid. They need to be treating the entire household. They need to be treating the child's toys, their bedding, everything needs to be treated to, you know, because the lice can be everywhere. Don't share hats, don't share towels, don't share combs or brushes. It's a problem that definitely requires education, but as I said, it's a more popularly known problem. So a lot of parents do know what they need to do. They do know that they can acquire the treatment for it over the counter. So just, you know, really basically making sure that they understand what it is that they need to do and how to do it. and making sure that we are monitoring that these things are being done, because this is a contagious issue and it can spread to more than just the patient themselves. So bites, ticks, if they live in a, or if they like to go to a wooded area, they may have exposure to ticks. Um, they can have a lot of issues with Lyme disease. This can be a deadly problem if it's not taken care of. So definitely, if they do have tick bites, making sure that we're providing education on the different treatments that they may need. This can last for a long time, even after they're over the bite itself. They may have some arthritis or joint pain because of it. Cat scratch disease, that is a real thing. Cats do have some bacteria in their claws, and if they break the skin with the scratch, it can become significantly infected. And in some cases, they may require long-term antibiotics to get over that problem. So that's definitely, if you have a family that has cats, that's definitely something that we want to be educating them about, because it's a real problem. Obviously, burns are an issue for children. This is one of those injuries that we want to try to prevent, but it is a common injury that can occur with our pediatric population. It's the third leading cause of death in children. There's different types of burns, the thermal burn that they can get from the actual fire, or if they are outside in the sun, they can get a thermal burn. Chemical burns, if they are exposed to different types of chemicals. Electrical burns, if they are exposed to electrical wires, or if they like to play with the outlets in the house and the outlets aren't secured, they can get that. Some complications that may occur, obviously shock is the one that we are the most concerned with any type of burn. That first 24 hours, we want to make sure that we're replacing their fluids, because they could go into hypovolemic shock. And then after the shock problem is infection, that we are concerned about, because obviously they are missing that layer or those layers of skin, so they don't have that protection from infection anymore. So we definitely are going to be concerned about that as well. Different types of burn. Your first degree burn is your more superficial burn. It may be kind of red. It's definitely going to be painful. Second degree is the superficial partial thickness or deep partial thickness type of burn. They may have some blistering, as you see in the top right there. Third degree or full thickness burns, as you see in your bottom right, those are considered third degree. Those are they can actually have nerve damage with these types of burns, so they may not be as painful as other types of burns, but as you can see, there's more significant skin loss there. So it's going to take probably some different surgeries, skin surgeries, skin grafting to fix this type of problem. It's going to be a more significant recovery time than with your second or first degree types of burns. These patients obviously are going to be having some scarring issues. Depending on where it's at, is a more significant emotional problem that we may have to deal with. And if they have this type of burn on their face, if maybe they were in a house fire and now they have burns to their face, obviously that's going to be more of a concern psychologically than in other places that can be easily hid or covered. The rule of nines does apply to children. It's just that the division of the different percentages of body surface are different for children. A small kid has a larger head than an adult does, so their head is more of a percentage than it would be in an adult. They have proportionately greater body surface area, skin to mass related to less muscle, less density of bones, and the larger head. Okay, so some nursing care for burns, minor burns, removing clothing that you can remove. You obviously don't want to force it to be removed, because that's going to only compound your problem. Cooling the burns immediately, because the skin will continue to burn even when it's been removed from the heat source. Washing with mild soap and rinsing well with water. Um, Applying a topical ointment or giving a tetanus booster that will be needed, covering with non-adherent types of coverings to the actual burn itself, because again, we don't want that to adhere to the skin, and then providing for comfort, maintaining pain management, because it's very painful to have a burn. No matter what kind of burn it is, it's still painful. Fluid resuscitation to prevent hypovolemic shock, meticulous wound care to prevent infection, nutrition for healing, management of pain, and making sure that you're assessing frequently to see if there's any types of changes. Nutrition, they're obviously going to need more calories for wound healing. 30% or more of the body, they may require up to 2,200 calories per day, or if it's significant enough, if a lot of the body surface area is affected, they may actually require enteral feedings because they're not going to be able to take in enough calories for wound healing. Or in some cases, they may not even be able to eat. So pain management, morphine sulfate is the drug of choice as far as opiates are concerned for your pediatric population. They may need some anti-anxiety medications because they're going to be very emotionally distraught. They're going to be very scared. They're going to need a lot of psychological support. And make sure that we aren't under medicating them. In the slide, it talks about adolescents, but any kids. You know, kids have pain, even infants have pain. So we need to make sure that we are managing that for them. And any non-pharmacological interventions like distraction, that's going to be important as well. Meticulous wound care, as I mentioned earlier, debriding the wound if they need it, making sure that the wound is clean. An eschorotomy, so if they have eschar on the burn, then making sure that that is getting removed. If no eschar or devitalized tissue is present, the wound can be treated with antibiotic creams and then redressed. Transparent occlusive dressing, so the wound can be easily assessed for infection. And in some cases, they use impregnated dressings to help with wound care. It actually will have different types of medications inside the dressing itself to prevent infection. Burn recovery, so burns are managed by phases of recuperation as well as the type and severity of burn. So the acute phase, obviously that's the time of the initial assault until wound closure. The second phase would be from the time of wound closure until scar maturation. In some cases, they are going to have scarring depending on the significance of the burn. So we need to make sure that we understand that. Very quickly here are some genitourinary conditions that you may see in the pediatric population. So children are at greater risk of fluid and electrolyte imbalances. They have a proportionately greater amount of body water. Vomiting and diarrhea can be a more significant problem for a child than it is for an adult. Greater potential of fluid loss from the GI tract and from the skin. So again, if they have some sort of a GI issue where they're vomiting or having diarrhea, or for skin, if they have a burn, they have a greater risk of a fluid and electrolyte imbalance. They have a higher metabolic rate. They have immature kidneys, so the kidneys are ineffective at excreting some of the waste products. They have a decreased ability to concentrate their urine because, again, the kidneys are immature. And they are at an increased risk of developing hypernatremia based on the inability to verbalize thirst. You know, remember, they're just kids. So a lot of the things that adults are at risk for, children are at a greater risk for. So that's definitely something, if you're going to work with the pediatric population, you need to be aware of. 3 different types of dehydration. The isotonic, where you are losing sodium and water in equal amounts. This is the most common type of dehydration. Hypovolemic shock obviously is going to be your greatest concern. The hypotonic type of dehydration, where the electrolyte deficit exceeds the water deficit. So you have hyponatremia. Physical signs are more severe with small fluid losses. And then you have the hypertonic type of dehydration. This is the most dangerous type, where water loss is in excess of electrolyte loss. So now you're going to have a higher sodium concentration. So with higher sodium concentration, you have more of a risk of seizures or loss of consciousness, alterations to their consciousness. Rye syndrome, you don't want to give a child that's had a recent viral infection aspirin because that increases their risk of Rye syndrome. Rye syndrome can cause lots of different neurological deficits and actually in some cases can lead to death. So you want to make sure that you're educating parents about that risk. Okay, so that's going to do it for this recording. If you do have any questions, please let me know.